Welcome everyone. Allow me to introduce myself. My name is Róbert Vass, and my thesis is the inflammatory processes of the urinary tract and its association with genitourinary cancers. I am a clinical doctor at the Department of Urology at Semmelweis University, and I am a first-year PhD student here at the Center for Translational Medicine. My supervisor is Gergely Bánfi, and my scientific methodology supervisor is Isabel, and an expert of our team is Tamás Szél. My vision is to reduce the incidence of genitourinary cancers, and my mission is to identify risk factors for these cancers. So we have two ongoing projects, both started this year, and in the next few minutes I would like to introduce them in more detail. So the first project is investigating the effect of lower urinary tract infections on the incidence rate of bladder cancer in women. So bladder cancer is the 16th most common cancer in women worldwide, and to put that number into perspective, this means 1 in 89 women will develop bladder cancer. And while the incidence of bladder cancer is higher in men, women tend to present with a more advanced disease at the time of diagnosis. Several risk factors have been well documented in the case of bladder cancer, and they can be grouped into modifiable and non-modifiable categories. Of the modifiable ones, smoking accounts for the highest number of preventable cases of bladder cancer. But interestingly, an infection by the blood fluke schistosoma hematobium, known as schistosomiasis, is also known to increase the risk of developing bladder cancer. Numerous studies also suggest that bacterial UTIs are also a modifiable risk factor for bladder cancer. And this last statement carries a lot of weight because 50 to 60% of women will have at least one UTI during their life. 20 to 30% of those women will develop recurrent UTIs, putting the number of women worldwide who will ever have a recurrent UTI during their life up to 400 million. So for this reason, it is imperative to answer the question whether frequent lower urinary tract infections increase the incidence of bladder cancer in women. To answer this question, we would like to compare the rates of bladder cancer in adult women who have no UTIs and adult women who experienced events of UTIs. And we have hypothesized that the latter group has an increased risk of developing bladder cancer. Based on the results of our study, these women who have an exceptionally large amount of UTIs, they could be followed more closely for a possible earlier detection of bladder cancer. So we have conducted the systematic search with the shown search key in 4 databases, netting us a total of 15,000 results, which after duplicate removal and selection based on title and abstract has netted us 275 studies eligible for full text selection. So as I've mentioned on the previous slide as well, we are currently in the phase of full text selection of our first project, which we aim to start in the following days. Our second project is comparing the composition of the urinary microbiome in bladder cancer patients and healthy individuals. So dysbiosis is an imbalance in the distribution and composition of a microbiome. And in the last 2 decades, this term dysbiosis has been linked to a multitude of diseases ranging from metabolic diseases to cancers. Most notably, strong associations were found in the cases of obesity, diabetes, and colon cancer. But causality is still a topic of debate, as most studies evaluating microbiome composition are of cross-sectional design. Although that is true, there are animal studies, longitudinal animal studies, which present considerable evidence for a causality on the side of dysbiosis. For example, in the case of obesity. These animal studies also suggest that there are certain bacteria which promote oncogenesis and others that are protective. And given that numerous cancers have already been linked to dysbiosis, and we know that there are certain bacteria which promote oncogenesis, it is only natural to ask ourselves the question, what is this relationship between bladder cancer and the urinary microbiome? So, accordingly, our clinical question is, or rather research question is, that is there a difference in the composition of the urinary microbiome in bladder cancer patients and healthy individuals? For this, we would like to compare different metrics, alpha diversity indices, and the relative abundances of bacteria in the microbiome of bladder cancer patients and non-bladder cancer patients. The implications of our study would be twofold. First of all, this would imply that there is a need for longitudinal studies, and while in the clinical setting, it could potentially be used as a biomarker, of course, depending on the results. As of yet, this project is in the preliminary phases. We have a preliminary search key, which we ran in two databases, PubMed and Embase, and through this, we have found a previous meta-analysis. Although it is a meta-analysis, they haven't conducted a systematic review as a part of it, and there is no current prospective registration similar to our topic. We also identified several key articles which we deemed to be comparable both in their study design and also their reported outcomes. And to summarize my projects, we are trying to finish them before next year's winter. And because what we do in science is ask questions, a fitting quote I thought of was that one of Confucius, as the man who asks a question is a fool for a minute, the man who does not ask is a fool for life. Thank you for your attention.
Congratulations, nice presentation and great progress. My question is regarding your first project. So why are you only investigating women?
Yes, so this is a valid question, and we discussed this extensively amongst us. The reason for this is that while in the case of women, lower urinary tract infections are for the most part synonymous with bladder infections or cystitis, in the case of men, it is not. It is a more heterogeneous entity, as involvement of the prostate is usual in the case of lower urinary tract infections in men. It is considered rare to be limited to only the bladder itself. So this is mostly the reason.
Thank you.
Thank you.
Excellent presentation. I have a question regarding your first topic. Do you intend to differentiate between different types of bacteria that cause the infections?
Well, we would like to. It would be interesting, but through the preliminary scoping of the literature, we don't think that it is feasible. So a lot of the data we might be able to extract from studies is based on questionnaires. So there is no report on the cultures that were or were not even performed in that case.
I see. And in your opinion, could the exact pathogen have an influence on the outcome?
Certainly, and that is why we have our second project, in which we would like to also address diversity, but also hopefully pinpoint some bacteria which are mostly related to the carcinogenesis, although again it is cross-sectional studies, so keep that in mind, yes.
Yes, thank you for your answer.
Congratulations for your presentation. I was just wondering that what is the method to determine the microbiota?
So it is a metagenomic analysis of the urine of the patients. So it is mostly 16S RNA sequencing.
Thank you.
Great presentation and progress.
Thank you.
And I would like to ask a question regarding your second project. In the outcomes, there are mentioned indices. Can you elaborate what that is?
Yes. So in microbiome studies, there are different indices on which we can report, and the most are a measure of alpha diversity, which is a within sample diversity, and the most commonly used indices for this are the Shannon diversity and the Simpson diversity or index, and these indices are a function of the proportional abundance of the bacteria isolated. So, because they are a function of the proportional abundance, it is possible to use in microbiomes which have a low biomass, such as the urine microbiome, which has a considerably lower biomass than, for example, the intestinal microbiome.